Clinically significant yeast. General characteristics, so yeasts are going to be unicellular. So they're fungi and they're the unicellular fungi. Sometimes yeast can look like multicellular organisms and they form this structure called pseudohyphae, but they're really just single-celled organisms. So colony color ranges from white to cream or tan, with some species forming a pink to salmon color. Some yeasts are referred to as phaeoid yeasts because they're darkly pigmented because of melanin in their cell walls. Colony texture, mucoid and flowing across the culture plate, butter-like, velvety to wrinkled, strain-to-strain variation in texture may be noted within a species. So yeasts kind of look similar to bacteria. Like when they grow on a plate, sometimes they look like bacterial colonies. There's some differences. A lot of times yeasts will grow wider and larger, and then microscopically, yeast cells are much larger than bacterial cells. When looking at them microscopically, yeasts sometimes are more oval shaped than they are like round. Like you wouldn't typically see perfectly round yeast. There are a few. Those are like encapsulated and they look perfectly round, but for the most part they're going to be larger in general, so it's kind of easy to differentiate yeast from bacteria in a microscope when you get used to looking at the different organisms. Candida. So the disease ranges from superficial skin infections to systemic disease. Candida albicans is the premier cause of yeast infections in the world. They may be opportunists in immunocompromised people, recovered as normal biota from multiple sites, including skin, oral, mucosa, digestive tract, vagina. But when host conditions are altered, disease may ensue. So these can cause infection in all of those areas, particularly the vagina and the oral cavity. Candida albicans is the known cause of thrush and our vaginal yeast infections. Recognized as an indicator of immunosuppression, they can evolve into serious infections in patients receiving long-term antibiotics or other chemotherapeutic agents. Serious infection is capable of dissemination. Candida glabrata may account for 21% of all urinary yeast isolates. They tend to be aggressive and difficult to treat with traditional antifungal therapy in patients with multiple comorbidities. So this is a picture of what Candida albicans looks like. Typical colony morphology is going to be creamy, but if grown in certain conditions, they can start to form these pseudohyphae kind of branching out. Here's what they look like under a microscope. Candida albicans is also positive for the germ tube test. So the germ tube test, you would basically take some Candida albicans, you would put it into some serum, and then you would incubate it, usually for a minimum of 4 hours, sometimes overnight. But Candida albicans will grow out this germ tube structure, which is easily identifiable. So if on the qualifying exam you are reading a question that talks about a type of pathogen that causes Candida-like symptoms and it grows the germ tube, you can safely assume that it's going to be Candida albicans. This is like the go-to test to provide more or less a confirmatory diagnosis. So here you can see a bronchial lavage, gram-positive yeasts with buds. Morphology is consistent with Candida species. Now they call it gram-positives, which we don't have gram-positive or negative yeasts. What they're referring to is the color that it stains. So if you perform a gram stain, it will end up appearing to be gram-positive because it will end up staining purple. Although it does not have peptidoglycan in the cell walls. I don't really like that the textbook refers to it as that, but here we are. So you can see the yeast cells here. They're very different than looking at bacterial cells. The bacterial cells are super tiny. These you can see they're larger, they're oval. Some of them are perfectly circular. You may even see some of them having budding occur. So these baby yeast cells budding off of the mama yeast cell, you can kind of see that in here. And here you can see pseudohyphae forming that's consistent with Candida species, where they're oval shaped and they're elongating into something that looks like hyphal segments. Candida auris. So this is an emerging multi-drug resistant yeast that's linked to a high mortality rates in hospital-acquired infections worldwide. In a hospital setting, it's likely transmitted patient to patient. Colonized patients should be placed on contact precautions. That's the recommendation of the CDC. MALDI-TOF can identify this species. Other notable species, Krusei tropicalis, Paropsilopsis, becoming major cause of outbreaks in nosocomial infections, nosocomial or healthcare-acquired infections. Species can be distinguished by differences in their carbohydrate assimilation patterns and other secondary procedures. The MALDI does a really good job at yeast identification now. It used to not, but now it's advanced to be able to identify various species of yeast. So here's some differentiating characteristics. You can go ahead and pause the video and review this. Moving on to Cryptococcus. So this is an important cause of meningitis, pneumonia, and septicemia. Most notable species is Cryptococcus neoformans, which consists of C. neoformans and C. D. neoformans. Major cause of opportunistic infection in patients with AIDS. Organisms are commonly found in soil contaminated with pigeon droppings. Most likely mode of transmission would be inhalation. Cryptococcus express a capsule that produces a characteristic mucoid colony. The capsule can be detected surrounding the budding yeast in CSF with an aid of India ink or nigrosin. The background would be black, and then a clear, unstained halo would be seen around individual yeast cells. Because of its low sensitivity, the use of India ink preparation is being replaced by cryptococcal antigen tests. So here you can see the Cryptococcus and this halo surrounding the Cryptococcus. Here you're able to see what the colony looks like. You're able to see it on birdseed agar, and then the white ones would be Candida albicans. So you can see the differences there. And then here's an India ink prep that shows the background is stained dark. This halo is the capsule, and then you have the yeast on the inside. The cryptococcal antigen assays and easy-to-use lateral flow assay are recommended for routine use in the clinical microbiology lab. Antigen assays detect both C. neoformans and C. gaddii species complexes in CSF and serum. Pneumocystis. So pneumocystis can inhabit the lungs of many mammals. Pneumocystis carinii was originally classified with the protozoa, and they even refer to it as having a trophozoite and cyst stage. But nucleic acid sequencing showed conclusively that the organism is a fungus. It is apparent from nucleic acid studies that P. carinii is not a single species. It's actually P. carinii and P. girovecchii. And that girovecchii is the species most often recovered from humans. Pneumocystis infection is acquired early in life. Serological studies have found that most humans have antibodies or antigens by 2 to 4 years of age. In immunocompetent individuals, infection is asymptomatic. However, in immunocompromised patients, serious life-threatening pneumonia can develop. Pneumocystis, initially identified as the causative agent in interstitial plasma cell pneumonia, seen in malnourished or premature infants. Since the early 1980s, it has remained one of the primary opportunistic infections caused or found in patients with AIDS. A high incidence of disease also results from the use of immunosuppressive drugs in patients with malignancies and in organ transplant recipients. Patients with pneumocystis may have non-productive cough, difficulty breathing, low-grade fever. Chest radiographs can be normal or show a diffuse interstitial infiltrate. Laboratory diagnosis. Appropriate specimens would be bronchiolar lavage fluid, transbronchial biopsy, tracheal aspirate, pleural fluid, induced sputum. Sputum is the least productive. Lavage and sputum specimens are often prepared using a cytocentrifuge, and that's going to help concentrate the cellular components of those specimens. Histological stains, GMZA and GMS stains are used. With methenamine silver stain, the cyst wall stains black. Cysts often have a punched out ping pong ball appearance. With the GMZA stain, the organism appears round and the cyst wall is barely visible. And here you can see what they look like microscopically. Calcofluor white can be used to screen specimens for pneumocystis and other fungi. This stain detects any organism that contains chitin in its cell wall. Fungi, yeast, and pneumocystis will fluoresce with a blue-white color when stained and viewed microscopically with ultraviolet light. Immunofluorescent monoclonal antibody stains are commercially available and are widely used. Here you can see fluorescence microscopy of the organism. So the laboratory diagnosis of fungi. So here, you may have seen this image previously, but we're over here with the yeasts. If the yeast has a germ tube, you can kind of automatically say it's Candida albicans, and then you can do biochemicals, and then there's special media that can be used. Cornmeal agar and other types of agar can be used. So culture media, sabrodextrose agar with or without antimicrobials, potato dextrose agar, brain heart infusion agar, enriched with blood and antimicrobials. Plates or tube media. Tubes are safer to handle and less susceptible to drying. Typically takes a group of tests to sufficiently identify fungi. Typically start by determining if the isolate is a yeast or a mold. Molds don't always produce structures to facilitate identification. There's molecular and proteomic tests that can be used with traditional procedures, such as DNA hybridization, DNA sequencing, MALDI-TOF, or PCR. Germ tube production is the easiest test to perform. Carbohydrate assimilation identifies which carbohydrates a yeast can use aerobically as a sole carbon source, creating an assimilation pattern. Chromogenic substrates based on different colors. Cornmeal agar for recognition of blastoconidia, chlamydia, pseudohyphae, and arthroconidia. And here you can see with yeasts, germ tube positive. If it grows at 42, Candida albicans. If it doesn't, it could be Candida dublinensis. If it's a germ tube negative, you would use cornmeal agar and then kind of go from there to differentiate the species. Typically, even though we have MALDI technology, we need to have other identifying characteristics back up the identification that's given by the MALDI. So we do have patient signs and symptoms, but in addition to that, we need other things. So we would try to look at colony morphology and try to look at what it looks like when staining it. Having something else like carbohydrate assimilation or the germ tube test would also be helpful. And here you can see the germ tube and pseudogerm tube production. Candida albicans on cornmeal agar is pictured, and pseudohyphae. Other miscellaneous tests for yeasts: potassium nitrate assimilation. Positive would be blue, negative would be yellow. Temperature studies, so as you saw in that diagram, if it can grow at 42°C, that could differentiate. And urease, so Christensen urea agar. Beta-D-glucan, it's an important component of the cell wall of various fungi, pathogenic yeasts, and pathogenic molds. This assay is a chromogenic test based on the activation of horseshoe crab coagulation cascade by beta-D-glucan and uses amoebocyte enzymes from Limulus polyphemus. Clinical studies have demonstrated the utility of this assay in the diagnosis for invasive fungal infections. However, various substances as well as some bacteria can lead to false positives. Cryptococci also lack that, so they're always going to be negative. In addition, this is a pan-fungal assay, so a positive result does not provide any information on the species. T2 magnetic resonance assay, a relatively new assay for the diagnosis of invasive candidiasis, combines nuclear magnetic resonance spectroscopy with PCR to detect Candida cells directly in blood samples. This, this assay has excellent analytical sensitivity, being able to detect 1 to 3 colony-forming units of Candida per milliliter of blood. So that means 1 to 3 cells of Candida per milliliter of blood. The results are rapidly available, usually within 4 hours in one study. The cryptococcal antigen test can be performed on CSF or serum. Several available assays to detect the component of Cryptococcus antigen, and there's types of assays that are available, including latex agglutination, EIA, and lateral flow. Immunodiagnosis, skin test reactivity to fungal antigens, uses antigen extract, only valuable if a patient has a history of non-reactive skin tests. Antibody detection assays, most common is probably double immunodiffusion. Individuals can have detectable antibodies but not active infection. Interlaboratory discrepancies have been reported. Antifungal agents. So current options for treating fungal infections include drugs primarily from 4 classes: polyene, azole, echinocandin, and allylamide. For many years, primary antifungal agent was amphotericin B, a polyene. This agent has a broad spectrum of activity in addition to fungicidal activity. Not only is it lethal to fungi, but it's also toxic to patients. The class with the largest number of agents is the azoles. The most noteworthy compound in this class is fluconazole, itraconazole, isovuconazole, posaconazole, and voriconazole. The azoles are important because they exhibit reasonable activity against fungi while causing fewer side effects. Fluconazole is the leading agent for treating yeast infections, but has limited to no activity against molds. Other agents worth noting are listed below. Clinical Laboratory Standards Institute has standards for antifungal susceptibility testing. There's special media plates that have to be used. And fungal susceptibility testing is gaining popularity, primarily because of that C. auris being so multi-drug resistant that now we're starting to consider more types of this testing. The largest barrier to widespread antifungal testing is the lack of established breakpoints for most of the agents. Breakpoints are now species-specific by drug, with results placing the organism categorically in the same manner as bacteria. The specifics vary by antifungal agent type. Until other drugs are studied and breakpoints are established, the usefulness of antifungal susceptibility testing will most likely remain limited. You can go ahead and review those points.